Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you for tuning in. Today, we're going to dive deep a little bit more into PCOS. And today, specifically, I'm going to go into the concept of insulin, the role that insulin plays in this. I want to go into how we would treat this. It's all about the weight gain that people have with PCOS that seems to be locked. And when they try different therapies, nothing seems to work well. Now, some of you, you get results with just the basic metformin protocol. And some of you, yes, you get results with intermittent fasting and those protocols. And some of you, semaglutide, tirzepatide, whatever, yes, they work. But the vast majority have challenges. I'm here to talk about those challenges and how to approach them and different ways to look into it and to get results. Before I get started, please scroll down a little bit in here. You're going to see there's that section where you're going to say subscribe. Let me know you like this. Comment as well. I really do appreciate your comments. With that said, let's get into it. I remember early in practice when I had a patient presenting to clinic and she was seeing a nutritionist. I was seeing her for something else, and she had hyperinsulinemia, and she was put on this barbaric diet. And it was so brutal for PCOS. And it was sad because it just didn't work. And she was torturing herself to make it work. A lot of you do that. I remember it like yesterday. You know, so many of the things that happened to me in the very early years of my practice shaped me as a physician. And I go back to that a lot when I do these episodes and these reels. I like to show you where I came from, you know, what formulated this. It was very early on. A lot of these things that changed me, that evolved me and helped me become the doctor I am today are those early years of experiencing and seeing women suffering. No one should be on a barbaric diet. I mean, if we're desperate and that's all I have, okay. But there's so much more I can do. So what can I do with this? PCOS has as a primary driver insulin resistance. Primary driver. Please know this. Let's talk about that. Insulin resistance happens when your cell's insulin receptors are not working correctly. So the cells need a certain level of insulin receptors, and say there's X amount of receptors here, and you release a normal level of insulin when you eat your food. The insulin then escorts glucose into the cell, and there you go. You have energy. Now, if the receptors become damaged, you're going to need more and more levels of insulin to get glucose in the cell. You need to keep increasing output, so your pancreas keeps making more insulin. That elevated level of insulin in your body is necessary to push glucose in the cell. Over time, if you keep having that problem, you're going to start seeing your glucose levels go up as well. That's a cofactor in this. But let's just keep with this. If the insulin receptors are damaged, and you have that damage to the insulin receptors is going to summon more insulin from the pancreas. That insulin sensitivity, insulin resistance occurs, and you're going to see that blood sugar happen. And that insulin elevation is, as I mentioned in a previous episode, the thing that drives up and fools around with your pituitary. And that's the thing that drives up your luteinizing hormone, which then leads to high androgens, leads to estrogen dominance and low progesterone, all the things we see with PCOS. Insulin receptor dysfunction is the first step, most important thing we should think about. How it's currently treated is just cut your calories, because that's an old-fashioned way of treating that. You know, it's like, well, if you have high insulin resistance, and high glucose, it's because you eat too much. A lot of you out there with PCOS have normal glucose. Your glucose is, 5.0, 5.4, 5.5, whatever. It's sub 5.6. You're not pre-diabetic, but you have high insulin. How is lowering your calories going to repair that? It won't repair that. But many of you, that's all you do because you have no other choice. No one ever tells you anything else until today. So what do we do? What do we do for insulin? I wrote this down because sometimes I talk on this. I'm like, I forgot to bring this thing up. I made a list. I checked it twice. Let's first start off with the things that I do that I like, that work, but maybe misinterpreted or misunderstood. Intermittent fasting, timed eating is important for insulin sensitivity and insulin resistance. It does help. Most of you out there would see it through the lens of If I'm going to do intermittent fasting, I'm going to starve myself for these amount of hours. You start with like, I'll do 8 hours, and then I go to 10 hours, I go to 12 hours, now I'm 16 hours, now I'm 18 hours fasting a day, and that's going to help me lose weight because I'm not eating during those times. So that 18-hour window, I should be burning calories and losing weight. That's not quite how it works. That's not how this will work, because that doesn't directly by itself affect the calorie restrictive component. Let me be clear there. Does not specifically affect the insulin receptor. This is very important I word this well. I want to do a good job with this. When you fast, and you pull back on your diet a little bit, and you don't eat during a period of time, like the overnight normally, your body goes into something called autophagy, where your body just basically cleans itself. It's basically cleaning up after itself. It's like a remodeling, redecorations. That's what's happening. And when you have a period of time where that's occurring, one of the benefits of that during that fasting time, one of the things that gets improved upon are your insulin receptors. This has to do something called mTOR. And I was debating whether I'm going to use the term mTOR in here and talk about all the weird stuff with that. There's enough videos out there and enough weird people out there talking about it and enough trendy dialogue about it. But I don't want to get down into that area. I want to be with you in this moment, be really clear with you on this, just between us. When you fast, my goal with you is not to really get a hypocaloric state, because a lot of you with a lower hemoglobin A1C and your lower fasting glucose, you already do that. If I have you when you are fasting and you're already doing your hemoglobin A1C say is 5.0, and I tell you to do an 18-hour fast, what am I doing to you? I'm stressing your body out. And what's the stress going to do? Your cortisol is going to be elevated. It's going to be more insulin. I didn't solve the problem. Maybe if I do fasting with them with a calorie deficit concept, I'm doing that in order to drive down these numbers. Short term, I could, and that might work. And that's why some of you are like, I fasted, it used to work, but now I gained all the weight back. Why? Good question. Because we created stress with the fast. The cortisol, the rebound insulin spike from the stress of fasting. Too much when your body wasn't ready for it. So fasting for the sake of calorie deficit is not working in this. It won't work in this. I want you to know this. It's not the calorie game. Be with me on that, because you see your weight is high and you're like, it must be me from overeating, because the whole world tells you that. The world is wrong. The world is wrong. We are right. Because I know you're not eating a lot. When your A1C is low like that, I know. So what are we going to do? When you intermittent fast, the goal with it is to switch your body into that autophagy, that self-cleaning. So I want to get your intermittent fasting out a certain period of time where I'm not creating strain on your body and I'm getting the benefit that I'm looking for. That's one of the first steps. That's important. So timed eating, no snacking between meals. I need as many gaps between meals as possible. And then I need to make sure you overnight fast for 12 hours. And I, as your doctor, would look at your cortisol. I, as your doctor, would look at your insulin. I, as your doctor, would look at the A1C. I would look at your luteinizing hormone. I'm running labs to make sure my diet is having impact on you in a positive way, but not stressing or straining you. If it's not lowering your insulin, I'm not doing my job right. Do you know what I mean? It's not working. I want it to work. So we're going to keep adjusting it. What else can I do? Supplements. Yeah, they work. I get sketchy about supplements because, there's so much shenanigans out there about supplements, and I'll see bad actors out there. So with PCOS and with weight and all these things, there's so many supplements out on the market that are like, yeah, this works. And they're selling you chromium for like a few $100s or something ridiculous, because they're trying to trigger your anxiety and your fear, and they're trying to trigger that insecurity in you, because that's a great motivator to buy things. I'm not going to sell you anything. I never have. I never will. So supplements, I'm going to tell you, are effective and can be helpful. Specifically chromium picolinate, zinc. I know magnesium is very efficient, very helpful. I prescribe that to my patients. Other things I prescribe to my patients is going to be, if necessary, I'm going to look at their calcium levels. Calcium does help. I prescribe antioxidants. Antioxidants are incredibly helpful with women with PCOS. That's a big role that goes on in there. Like, well, Brendan, Dr. McCarthy, what doses? Great question. This is the part that's going to be crazy. I run the lab. I'm not going to tell you to take something if I don't see you needing it. And if I see you need it, I'm going to prescribe it correctly. I run the zinc panel on you. I run the magnesium panel on you. I run all these labs on you to find out where you are. And then I make my decision then. Now, say you're in a place where your doctor won't run the labs. What doses do you use? It's very personal. I'm going to be very honest with you on here. I'm not going to sit here and tell you what milligram doses to do anything. I'm doing that on purpose because it's important to adjust doses based on success. This has been my understanding throughout life. If you give a person magnesium, I've had this happen. I had a patient who had constipation secondary to magnesium deficiency because she had estrogen dominance. So when your estrogen is very high and we give you magnesium, what's happening is that magnesium plays a role with estrogen detoxification pathways. Magnesium plays a role in the liver, and it plays a role in that whole process of breaking down estrogen. So if you have estrogen dominance, too much estrogen, chances are you're going to have low magnesium. So I'm going to prescribe magnesium. I've seen patients go online and see magnesium, and they're like, well, I'm just going to take magnesium, and they'll take 140 milligrams or something. That will do nothing. Nothing. Then I've seen other people do 800 milligrams to 1,200 milligrams, which is pretty heroic dosing. The thing is with these, we need to sit down with you and understand where you are and then approach it. So I want you to know these are nutrients I use, and I want you to know that I want you, if you were to use these, to have your physician sit down and help you target it. Because what if you take that magnesium at 180 milligrams and you said magnesium doesn't work? But it does work. Supplements, I think, are very helpful. So fasting to get mTOR engage or autophagy, remove mTOR rather, and get autophagy going, yes, big. And supplements to help nurture that pathway. I'm going to talk about something controversial and heretical, because it wouldn't be an episode if I didn't. Rapamycin. Rapamycin is a fascinating medication that has significant impact on PCOS on women. Rapamycin. You have to be very careful with dosing rapamycin. I'll be clear on that. And rapamycin at too high of a dose is immune modulating and immune suppressing. Too low of a dose doesn't really work. You need to find the right dosing on it. And the method of dosing it, a lot of times in our practice, we'll only do it once a week. You take your rapamycin once a week. We prescribe it. It's prescribed medication. And it's the benefit of it, the impact it has on the insulin receptor is significant and measurable with lab work. So we'll write the rapamycin for the patient to see. And you're like, Brendan, what does rapamycin has it do? Mammalian target of rapamycin, or mTOR, which I mentioned earlier, which fasting engages. mTOR, that receptor, mammalian target of rapamycin, rapamycin specifically hits that. Rapamycin pushes your body into autophagy. It's like helping your fast get better traction. It helps your body heal itself better. That's what rapamycin does. Proven in the literature. Deeply proven. This is an off-label use of it, though. The FDA has approved rapamycin for, to prevent, at high dosing, to prevent organ transplant rejection. True and good. Still, as a physician, part of what we do, every physician does, is use medications off-label. We are supposed to do it. Does that mean the medication is not FDA approved? No, that does not mean that. What it means is that it is FDA approved as a medication. We are allowed to prescribe it. You can use it if you can show the benefit to the patient. So when we use an off-label medication like rapamycin, how do we do it? We sit down with the patient. We say, this is what I think will work. These are the pros and cons of it. This is the research behind it. This is how I expect it to work. This is how I'm going to verify it works. This is why it's safe. This is where it would not be safe. This is how I'm going to make it stay safe for you. That's how you use off-label medication. That's important. Anybody who says that off-label medication is, illegal or dangerous isn't really paying attention. That's not medically true or sound. So rapamycin in this case is an important component, in my opinion, for addressing the core cause of PCOS, fasting and rapamycin, hands down. Supplements after that. What else do I do? The diet that you do, and many of you have done, a lot of you do low carb, I get it. I've done that too, and ketosis diets, and you'll do carnivore diets, and you'll do these diets that are very, very low carb. And that's effective to a point. It doesn't always work, as I mentioned earlier, is when you're doing some of these extreme diets, any really far controlled diets that are very extreme in the sense of you're only doing you're eliminating one whole food group, or you're only eating one specific type of food. These are extreme by nature. That's how I feel about medicine. Feel about diet. So when you do those types of diets, you can have success, but the success will be limited in my experience and does not last forever in these cases, because the stress of it and the difficulty of having proper nutrition on these diets is a problem. And nutrition is a big part of treating this. You need to have the correct micronutrients around to benefit the person in front of you. So I want you to know, when I do a diet for these women, I try and avoid doing diets that are difficult or stressful or limited in micronutrition. My favorite diet to do, and I mean this wholeheartedly, and I give this my whole full-throated support, is the Whole30 diet. I have done that diet. I prescribe that diet. I live by that diet. That is the key diet for my patients. It works. A close second to that is going to be the Mediterranean diet. But the Mediterranean diet is so abstract. People are like, well, I can have spaghetti and meatballs. That's a Mediterranean dish. It is a Mediterranean dish, that is true. And a good set of a good spaghetti meatballs is pretty dang delicious. It's true, but that will not help you. That's not the Mediterranean I'm trying to talk about. So Mediterranean is tricky with patients. You have to spend time with them doing education. So with this diet, we do a Whole30 diet. And when we have this diet with patients, I want to be very clear with you. Telling someone to go home and do Whole30 diet can be tricky, and it's not easy. And a lot of times they feel alone and you get lost. We sit down with our nutritionists. My partner in the practice, my wife, she's my partner in the practice. She does nutrition at the office, and we really work hard to make sure it's accessible and understandable. And we stand beside you and help you get through these diets. So it's important to consider, do you need someone who's been doing this for a while? That doesn't mean you're going to go to your doctor's office. It could be you talk to someone who's been doing these diets for a while, maybe, or maybe reaching out to the Whole30 website and asking them for some guidance. I know them. They're very helpful people. I've interacted with them on several occasions in my career. I think very highly of them. So that's a good option, And with fasting, another great resource, Dr. Jason Fung. I just love his work, but also I like the kind of person he is. His website has so many helpful tools there. So when you do these things, you don't have to onboard a real expensive nutritionist if you can't afford that, or if it doesn't seem to work for you. There's these resources you can do online with these people. And I know these two companies are very, very ethical people, and my personal experience with them as a physician, so I do recommend them. So when we have you do a Whole30 diet, say, I prescribe that for you, I'll sit down with you and we'll create, or the nutritionist will sit down with you and create a diet plan. You'll be like, okay, let's make a menu for the week. And you create a menu of all the things you want to eat. And then we create a shopping list with you. And then you go fill the shopping list and you prepare the food. And we make a shopping list and a menu that you can do. Okay, a menu, if you're like, I'm going to do this complex dish, you got home from work at 6 o'clock, you don't have time to make a complex dish. You want to throw yourself in a crock pot, or you want to throw yourself in an Instant Pot, have it done. So we make those diets work for you. So a Whole30 diet is a key part of this for me. I've had tremendous success with it. Why is it good? It emphasizes micronutrition through plant-based calories. So we're not doing grains on it. Okay, so your carbs from there are reduced, but you're going to be getting a lot of vegetables and fruit in there. And the vegetables and fruit in there are going to give you the micronutrition that's going to have the zinc, that's going to have cobalt, which I didn't mention a minute ago. That's another micronutrient that's helpful. It's going to have in there the chromium. All those micronutrients in the foods around you are more bioavailable and work better in a food substrate. So we make sure you do that healthy diet. This is how I approach my patients with PCOS, to make sure I go after the core part of this that is getting to them. Now, if you think about it, what's different with what I just described with what people are prescribed in their standard appointment with their physician? The doctor will say, just cut your calories. They may say do keto, maybe, rarely. But they'll say something like that. They'll just say, go on Weight Watchers. And there's nothing wrong with Weight Watchers. There's nothing wrong with keto. These are good protocols for people because they make changes. But this is a diagnosis with pathology. And PCOS does not always respond to keto. It doesn't always respond to Weight Watchers. That's not a dig on ketosis diets. It's not a dig on Weight Watchers. That's just a fact that the insulin receptor is damaged. We need to target it and repair it. So I believe using micronutrition, using timed eating that's very careful, how you time it. I believe that using a diet that is rich in micronutrition and low in the insulin index of foods. That's what the Whole30 diet is. These are foods that don't stimulate a lot of insulin. Foods can stimulate insulin, and foods can stimulate glucose, by the way. There's the glucose index of foods, and there's the insulin index of foods. You need to watch the insulin index, because that's another thing that will be triggering people with PCOS. So we want to make sure you're doing a diet that's down that road of insulin index of foods and doing something like that Whole30 diet. That's how we get through that. 2 more things to add in here that are important that I bring up. These are herbs. Berberine is a tremendous asset to you in PCOS. It's a tremendous asset. And I'm going to do dose and I'm going to do brand right now, because herbs are tricky, because if you don't get it from a good source, you run the risk of, number one, getting nothing that works in there, because it'll say, oh, this has berberine in here, but really how much active component of the plant is in there? So Gaia, Gaia, Gaia herbs, they don't know me from a bar of soap. They don't know me at all. I love Gaia herbs. I've known them and loved them since I first started doing this. It's one of the more effective and ethical and high quality companies out there, and you find it in almost every single health food store. And I still stand by them. You can buy your berberine from them, and you look on the label, and it'll even say how much active compounds are in there. They measure it within their chromatography. They really do care about their product. So I would use Gaia Berberine Plus or one of their other berberine compounds. I would not do the liquid. I would do the gel caps, because liquid berberine tastes terrible. Terrible. Compliance drops off with liquid berberine. So you want to do is a gel cap to get the best absorption rate in there. That's been my experience with it. Another herb that I'm going to bring up is metformin. You heard me right. I call metformin an herb. Metformin originated as an herb. That's what it started as. And it was repurposed as a pharmaceutical. They pulled the active ingredient out of there, and that's how they made metformin. Metformin is largely based upon an herb. That's it. French lilac. That's it. So when you use metformin, that's a plant-based medication, even though it's been, turned into a pharmaceutical. I have no problems with metformin. I don't think it's a bad thing. I think it's bad to park you on it and not try and fix you with all the other things, with the timed eating, with targeting the insulin receptor and trying to repair that. I think just parking on metformin is just not truly a good job. So I put you on metformin along with this other protocol, and I watch how you progress, and I see how you go. So this was my dietary approach to treating PCOS, and I hope this helps. It's by no means exhaustive, but it gives you an idea how I look at it and how I unravel it. Your comments mean so much to me, because it helps me do a good job at this, because I do want to do a good job. I'm not here to sound smart. I'm not here to sell you anything. I just love doing this. I love my work. I really do. It's a very rewarding thing that I do, and it gives me fulfillment at a deep level. And to be able to share that is priceless to me. That's more important to me than anything else, is being able to share that. Knowledge only has value if you share it. It has no other value in life. So please like, share, and subscribe. And I'll see you at the next episode. In the next episode, we're going to go a little bit more into how to treat PCOS. I'm going to get more specific on a couple other therapies that we employ in here. I'm going to talk more about progesterone, which is my favorite. So the next episode, we're going to talk about progesterone. Thank you again for tuning in. I'll see you again the next time.